Good morning, everyone. And today, Dr. Panda will be presenting the case and it will be moderated by Professor Nagaraj Palankar and Professor Sharvari, Pujari, and Dr. Mahesh might be joining shortly. So you can, in the meantime, you can start the case. Dr. Nagaraj and Sharvari, you can take over.
Yes.
Yes, sir.
Thank you, sir. Sir, today's case presentations.
Yes, we can start.
Thank you, ma'am. My patient, 15-year female student, a resident of Telangana, presented with chief complaints of multiple episodes of bloody vomitus from the age of 3 years. Coming to history of present illness, patient was apparently all right till the age of 3 years when she had first episodes of bloody vomitus of approximate quantity of a teacup, which was associated with clots and followed by which she also had past black colored tarry stools for the next 5 weeks. She was evaluated for the same at local hospital. From there, she received 1 unit of PEG RBC and she was later referred to a tertiary center in Hyderabad, where she underwent an endoscopy bending and was discharged after 5 days. About 3 years later, she had a recurrent episode of blood vomitus, which was again associated with clots. She was admitted and undergone similar endoscopy procedure and was followed with regular endoscopy once in 6 months. She had a recurrent similar episode of bloody vomitus about 4 years later, that is the third time. She underwent bending once again for the third time. Now she also underwent a ultrasound guided biopsy of liver. She was also started now on an oral medication twice daily, which has been continued till date. Coming to present illness, history of present illness. In 2016, she underwent bending for the 4th time on routine follow-up. She was kept on regular follow-up for next 4 years, that is till 2020, followed by which she was lost to further follow-up, but she continued advised prescribed oral medications. In December 2023, that is after 3 years of loss of follow-up, she had a recurrent episode of blood vomitus, about 100 to 200 ml, containing clots, followed by 2 to 3 bouts of further blood vomitus over next 3 to 4 hours. After which she had a loss of consciousness. She was admitted in an ICU at a tertiary center and received 2 units of blood transfusion. She once again underwent bending and was discharged after a week. Now, this month in June 2024, she again had a recurrent bloody vomitus, which was not associated with clots this time. She again underwent bending now. There was no history of abdominal pain. There is no history of loss of weight or any history of jaundice. There was no history of nausea or vomiting or any kind of easy bruisability in past. There is no history of easy fatigability or any growth retardation. There is no history of any intake of alternative medication or abdominal distension or any altered sleep rhythm. There is no history of altered bowel habits. In past history, there was no history of any other medical comorbidities. She had any previous surgery, no history of suggestive umbilical sepsis in perinatal period, and no history of any admissions to NICU. For coming to personal history, sleep, bowel and bladder habit are normal, appetite is normal, there is no addiction, and consumes mixed Indian diet, hails from a village in Telangana of upper middle socioeconomic class. Family history is not contributory. To summarize my case, patient is a 15-year-old female with multiple episodes of painless hematemesis since the age of 3. She had been in follow-up 6 monthly and had undergone endoscopy treatment for multiple times successfully and taking a prescribed medication twice daily. There was a loss of follow-up for 3 years, after which she experienced a single episode of significant bleed associated with loss of consciousness, which could be managed with 2 blood transfusions and endoscopy therapy. There is no history of abdominal pain, jaundice, or easy bruisability, easy fatigability, abdominal distension, or any altered sleep rhythm.
So, Ashabad, what is your diagnosis?
Sir, patient started bleeding is
Ashirwad, Dr. Ashirwad.
yes, ma'am. Sir, patient started
Yes,
bleeding.
same. What is the diagnosis at this stage you feel?
At this stage, ma'am, I feel it's a non-cirrhotic portal hypertension leading to bleed, most likely, ma'am, due to early age of presentation, most likely extrahepatic portal vein obstruction.
Okay. So your diagnosis is EHPVO, isn't it?
Yes, sir.
Okay. Would you like to consider anything else in the differential diagnosis?
Sir, yes, sir. I could have, sir, when there possibility of chronic liver disease, sir. But even in spite of multiple times bleeding and few times significant blood loss, there was no decompensation, there was no ascites, there is no jaundice feature, sir.
So which chronic liver disease can you expect where the presentation is at age of 3 years?
Sir, any congenital disease, sir, most likely, sir, Wilson disease, sir, can be. Sir.
So anyway, here the history is, like, yes, there's significant history here of banding, which
Yes.
almost clinches a diagnosis here, right?
Yes. Yes.
Okay. Dr. Sharvari, you want to ask something?
Yes, so what is the presentation, usually presentation age of EHPVO, and what is the age in this case?
Ma'am, usually patient present by the age of 5 to 7 years, ma'am. And present, in this case, patient presented from the age of 3.
So do you think what could be the etiology?
Ma'am, there is a chance of perinatal sepsis, ma'am, but there is or umbilical during birth, ma'am, birth at home, or any dehydration during birth period, ma'am. But in past history, negative history is given. So.
Okay, so you ideally should have asked up for this history, but in how many cases this history is positive?
Ma'am, very rarely, ma'am. We find very rarely this case.
In percentage, you can tell.
Ma'am, around 10%, 10 to 20%.
Yes, so in less than 10%, you will really have the positive history of this. But for the sake of knowing this, what are the reasons of umbilical sepsis?
Ma'am, improper clamping. Second, any umbilical catheterization or any umbilical not maintaining sterility during procedure.
Yes, so rather than besides sepsis, the inflammation also, simple inflammation also can lead to this. And more importantly, the episodes of dehydration and loose motion will be more correlating or will be found more commonly. Okay. So, what is the natural history? I mean, the patient is now 15 years of age, right? First presentation is at 3 years. So, what do you expect till now the patient might have developed? What is the natural history of EHPVO in short?
Patient due to portal venous thrombosis, ma'am, patient develop portal hypertension, and its complications like varicose bleed, ma'am, or further leading in portal cavernoma, ma'am, leading to any which present usually late, ma'am, portal biliopathy.
Okay.
Later. And another feature is splenomegaly, ma'am.
Right.
Yes, splenomegaly, and if possible, associated symptoms of any hypersplenism, which patient develops later on.
Yes. And one more important thing, a patient being presented so early, what could be the other clinical presentation or other important thing you could ask or you could see in this patient? There might be, it might be present associated with EHPVO because of EHPVO.
And there are chances of rectal bleed, ma'am. But
that is why I asked you what is the natural history. By this age, if a patient presents at 3 years of age and now by 15 years, what can be one more thing? There can be growth retardation.
Yes, ma'am. Their growth retardation.
Yes. So by now the patient might have developed hypersplenism. You could ask for that.
Yes.
Patient has already developed varicose bleed, and patient could develop growth
Stunted growth.
retardation. Yes, and portal biliopathy might be there on imaging, or maybe it will develop in next few years.
Later.
That can be the expected natural history of EHPVO at this stage. Okay. So continue.
Coming to ma'am, physical examination, patient is conscious, cooperative, and well-oriented to time, place, and person. Thinly built and adequately nourished. Breath holding time is 38 seconds. BMI shows 18.5 and weight shows 40 kg and height of 1.140 centimeter, which is less in terms of Indian value for a female of age of 15 years. Also 72 per minute, and blood pressure is 126 by 80 millimeter of mercury. There is no pallor or any icterus, cyanosis, edema, clogging, or lymphadenopathy. There is no signs of malnutrition, no signs of dehydration, no signs of liver disease. Coming to inspection. Yes, ma'am.
Hello.
Yes, ma'am.
So, depending upon the height of the patient, can you say the patient is short in height or has growth retardation?
Ma'am, with compared
what if the patient's parents also are short stature?
Yes, ma'am. Ma'am, we have to both calculate either there is stunting and wasting. We have to see both. If both is present, then we can say it's a growth retardation. And also comparing, taking with respect to the parent side and nutritional value, if any.
Okay, so we again, we have skipped it in the history, but in history, what you should ask for that, rather than parents with whom you can compare the patient.
Siblings, ma'am. Siblings, close siblings.
And if the parents are short statured, siblings will also be short statured.
Then in that case, ma'am, I will look for any other muscle wasting in present.
In history, I am going back one step, but still.
Ma'am, in academic activity in school, I look for is there any how patient is performing in academic activities.
Yes, and height and weight also you can compare with the schoolmates, with the batchmates.
Yes.
Right, and then also you can ask about the academic activity and assessment. Okay.
Sharvari, if you just take the BMI here.
Yes, sir.
Isn't it in a normal range?
Yes, sir, it's normal.
Okay. I think you can proceed. Yeah.
Yes. Sir, coming to inspection, fullness is noted in left upper quadrant, abdomen is flat, and obliquus is central and inverted. All quadrants moving corresponding with respiration. There is no visible vent, or peristalsis, or pulsation or scars. Hernial orifices are intact, no visible cough impulse is seen. On palpation, there is no tenderness. Palpable spleen, which is non-tender, is moving with respiration and extending just beneath the left midclavicular line, about 4 cm from the left costal margin. Hernial sites are normal, no other palpable findings. On percussion, liver dullness from 5th intercostal space, liver span is 10 cm midclavicular line, flanks are tympanic, dull knot over left hypochondrium. Coming to auscultation, normal bowel sounds are. On DRE, distal rectal examination, sphincter tone is normal, no palpable mass, gloved finger stand with yellow stools. Respiratory system shows bilateral vesicular breath sound. There are no added sounds. On cardiovascular system, H1, H2 normal, no murmurs. In central nervous system, higher mental functions are normal, no focal neurological deficits could be seen. Coming to summarize my case, my patient is a 15-year-old patient with recurrent episodes of hematemesis managed by endoscopy therapy and blood transfusion since the age of 3 years. On follow-up on endoscopy, with one incidence of loss of follow-up at times, which was for 3 years, having undergone last endoscopy therapy this month, is without any features of decompensation since last 12 years. Examination reveals moderate splenomegaly and BMI of 18.5 kg per square meter with a height of 142 centimeter and weight of 40 kg, which shows growth retardation without any stigmata of chronic liver disease. My provisional diagnosis, sir, is a case of non-cirrhotic portal hypertension, most likely extrahepatic portal vein obstruction.
Okay. So now the patient's recent presentation is with upper GI bleed, right?
Yes, ma'am.
Yes. So now, how do you want to proceed further? What do you want to do?
Ma'am, at this time, I want to investigate the patient. I want to know the blood parameters, that is complete blood count, ma'am, CBC and LFT and RFT, ma'am. And if PTIN are available, any coagulation profile is done.
Ashirvad, I would
Okay.
just like to interrupt you for a moment. Do
Yes,
you want to consider non-cirrhotic portal fibrosis in differential diagnosis?
yes, sir, I might consider, sir.
So what is against NCPF here?
Sir, a main factor, sir, age, sir. Age is the main factor, sir.
Yeah.
NCPF starts late, sir.
Okay. Yeah, so what are the investigations you would like to have?
Sir, I want
And
to look.
any other, just to add in that and maybe further thinking about it, is this the only diagnosis at the age of 3 years? As I again and again said, that this can be the most common diagnosis, I agree, but for the differential diagnosis, because sir is asking,
Yes,
what can be the other thing if you want to stretch your imagination or include all the diagnosis possible?
then chronic liver disease could be differential, like can come in a differential diagnosis.
Okay, not chronic liver disease. In non-cirrhotic cases, what can be the other causes? Can there be any other cause other than EHPVO?
NCPF, ma'am, non-cirrhotic portal fibrosis.
Non-cirrhotic portal fibrosis develops at this age?
No, ma'am, it develops later.
No. So what can be the other cause of non-cirrhotic portal hypertension developing at this age?
Pujari, ma'am, Pujari can occur.
Pujari can occur at this stage. It is non-cirrhotic we want now. What can be the causes? What can be the rare causes? Or giving you a hint, at the age of 3 years, maybe before than 3 years, say the patient has presented to you at 1 year, 2 years of age.
Ma'am, portal vein hypoplasia, ma'am, can be.
Yes. So there can be a rare case of congenital malformations of portal vein. This can be a rare cause if you just want to include all the causes.
Yes.
Okay.
So coming to investigation, I would like to look for CBC, complete blood count, and LFT, and PTN, any coagulation profile down. And hemoglobin shows 10, TLC count shows less, ma'am, 1600 cells, platelet is 60,000. RFT looks normal. Case of LFT, there is total bilirubin point.
Okay, what else you want? You said HbCBC, LFT, RFT. You said anything else? You want anything else?
At present, no, ma'am. CBC
Okay, so
shows,
what it shows?
CBC shows features of thrombocytopenia with leukopenia.
Okay. So that is suggestive of in presence of and clinically you have got splenomegaly, right?
Yes, moderate splenomegaly.
Okay.
It
So what you can call this picture as?
Hypersplenism syndrome.
Very good. So what is the definition of hypersplenism, just to revise for yourself and for others also?
Yes, ma'am. Hypersplenism with 4 criteria, ma'am. One, cytopenia, one or more cell lineage, and then compensatory hyperplasia of bone marrow, Then correction of cytopenia after splenectomy. Then there is splenomegaly.
Yes, it is normocellular, or bone marrow can be normocellular also, or
Yes, ma'am.
hypercellular, but should not be hypocellular.
Yes, ma'am. Hypercellular should not be hypercellular.
Right. Yes. So this is the hypersplenism. Now, what is the indication for shunt surgery as far as hypersplenism is considered?
Yes, ma'am. In case of hypersplenism is an absolute indication for shunt surgery.
Only hypersplenism is the indication of surgery?
Only hypersplenism is indication of splenectomy, ma'am, not shunt surgery. But bleeding, if patient has features as this patient of EHPVO presents with recurrent bleeding, ma'am, and symptoms of already the investigation shows there are features of hypersplenism, then shunt surgery can be done.
You know what is symptomatic hypersplenism?
Yes, ma'am. Symptomatic patient present with bleeding or easy bruisability or infection, multiple recurrent respiratory infection. Then there are easy fatigability like anemia, chronic anemia present.
Yes. So bleeding can be a symptom of variceal bleed, right?
Yes, ma'am.
Bleeding cannot be, bleeding may not be a symptom of symptomatic hypersplenism. What
No,
is
ma'am.
what symptoms are included to call it as symptomatic hypersplenism?
First,
Symptoms
ma'am,
of
internal bleed or any easy bruisability, ma'am.
okay, low platelet.
Low platelet count, low platelet count. Second, a recurrent infection due to low cytopenia.
Okay, and
lipopenia. Third, there is anemia. Patient is
right, and yes. So symptomatic hypersplenism is the indication for surgery. Right, not
Yes,
only hypersplenism.
not only hypersplenism.
Right. So along with this picture, you have to see whether the patient has symptoms pertaining to these this blood picture.
Yes.
Okay. So we have now reached to a conclusion that patient has hypersplenism.
Yes.
Okay. Proceed. Then
Now,
what next?
I want to look upon the upper GI endoscopy done, recent upper GI endoscopy. Recent is upper GI endoscopy says grade 1, grade 2 varices, post-eval scarring noted, mild portal hypertensive gastropathy, and prominent veins noted in fundus. Rest and normal. Altered blood noted in stomach. Altered blood noted in stomach. I want to know, is this endoscopy after during EVL or after how many days of EVL? Last EVL, the recent latest EVL.
This was done after 5 days of recent bleed. And during this, she underwent banding after this endoscopy.
Okay.
So you want the past endoscopies as well, is it?
Yes, sir, yes.
This endoscopy was done at the age of 14 years. So this is the one which she had a last significant bleed, so other than the recent one.
2 columns of grade 1 varices only, sir.
Okay, but endoscopy is done in June, say June, in the month of June, right? Now it is 3 weeks or EVL is done. Anything
Yes.
more important you want to know or you want to do to confirm your diagnosis first? Or any previous report you want to see?
Ma'am, I want to see
right now patient is not bleeding, right? EVL is done.
Yes, ma'am.
Right.
I want to do, ma'am, I want to see the liver biopsy report they have done and the previous if any ultrasound abdomen has been done or not.
Any report which by which you want to confirm your diagnosis, I say.
Ultrasound report, ultrasound whole abdomen can be.
What will you see in the ultrasound? What are you going to look for?
Ma'am, in ultrasound abdomen, I want to first see the liver, how it is, the echo texture, if there is any.
You want to confirm that patient is
Yes,
first time come to you,
yes,
and now you want to just see few things in the ultrasound and you are happy at your diagnosis that you had already diagnosed this clinically.
yes,
What are those features to be seen on ultrasound report?
yes. I
You
want to
want to
look
see
for
liver
portal
echo
cover
texture
number.
directly?
I want to look for portal cover. First splenomegaly, ma'am. If there is any
Okay.
splenomegaly or not, then the liver followed by splenoportal axis, and then if any portal cover number in the splenoportal axis, ma'am. Or if any ascites is present or not, also rule out ascites.
Okay. So in short, what are the USG signs of EHPVO, USG features?
Yes, ma'am. In case of EHPVO, there is a splenoportal axis thrombosis and splenoportal axis.
Thrombosis is seen always. Thrombosis is seen
No,
in how many
it cannot
patients?
be.
How many percent?
In USG, ma'am?
Oh, yes, on USG.
I don't know the percentage.
When the thrombosis can be seen on USG?
Ma'am, in
At
chronic
what age
cases,
this patient has developed thrombosis according to your assessment?
most likely, ma'am, from the age 1 to 2 years, ma'am. Then
Right. So you will see thrombosis now.
mostly no, ma'am. If already no, ma'am, I won't see.
Okay. So what you will see?
Ma'am, there will be multiple collaterals, hepatopetal collaterals, most likely cavernoma, portal cavernoma.
Okay.
And
So
there is,
portal vein will be replaced by large
yes,
collaterals, and that will be called as portal cavernoma.
yes.
Right. Then
Then
what else?
spleen, any patent splenic vessel is patent or not, and
That
patency
will
of
be seen
SMD.
only on USG.
No, ma'am, it can be better seen in CT, but it will help further.
But on USG, if you are, yes.
Any gallstone, ma'am, any gallstone or
So
any
with
CBD.
USG, what you have to add to look it at USG?
Doppler, ma'am. Use the Doppler.
Yes, Doppler you can add. So what you can say is you want to first confirm your diagnosis of EHPVO. So you have to look at portal cavernoma, presence of splenomegaly, collaterals near the splenic hilum, collaterals everywhere in the omentum, plus
Yes.
complications of this in the form of
Yes.
what? What you don't want to see on USG are the things like gallstones.
A gallstone or any biliary intrahepatic biliary tract
Right, and
dilatation
then
or
at the end of it, you want to look at ecotexture of liver and ascites.
Yes.
Right. Okay. So now we will see the USG report.
Use the abdomen with collar Doppler shows liver measures 11.6 centimeter with normal echo size and normal parenchymal ecotexture. There is no HPRD. CBD is normal. Portal vein is thrombosed, replaced by multiple collaterals. Gallbladder is well distant, no calculi. Coming to spleen, it measures 16.5 centimeter, enlarged in size, normal in ecotexture. Evidence of splenic hilateral collaterals present. Splenic vein is 11.2. Left renal vein measures 7.4 mm. Pancreas is normal. Kidney is normal in size with smooth contours. Parenchymal ecotexture normal. No hydronephrosis or calculus. Rest are normal.
Okay. So you said you have you want USG now. You have the diagnosis. You said you want biopsy. Why do you want biopsy?
Ma'am,
Still
I
you
don't
have.
need biopsy, but it has been done, so I want to look at the report.
How do you know it has been done? Do you want to do or not?
No, I don't want to do, but I can do this biopsy during operation, ma'am. Intra.
During surgery. Now you want anything else? You don't want biopsy.
No, ma'am, I don't need biopsy.
So what next investigation you want?
Ma'am, I want to see the short, yes, CT of abdomen.
Okay,
CT
for
photo.
what? I mean, what is your plan and why do you want CCT?
Ma'am, I want to, though already it has been given, but I want to localize the anatomy of splenic vein and left renal vein and plan my surgical.
Okay, so you are thinking of surgery for this patient.
Ma'am, patient, at first with history, I was thinking of managing patient with endoscopy only, as patient was
Okay.
well managed with endoscopy. But now there are features of hypersplenism, though it is not symptomatic. But
Okay.
patient is young, ma'am, and sometimes in some cases, in the cases like this, we can use a sound surgery as a secondary prophylaxis for future bleeding and also addressing the concern of the hypersplenism.
Any other justifiable indication of surgery in this patient? Clear indication for surgery?
Ma'am, it will, after the secondary prophylaxis, the rebleed rate will be very low, ma'am. And it will address hypersplenism and with splenomegaly, which obviously.
So anyway, now, so you want a CT, is it?
I think by mistake or some he has left the meeting. He will rejoin, I guess.
Okay.
Yes. Patient without features of those findings blood picture, ma'am, I would like to go for only endoscopy therapy, follow-up and treatment endoscopy basis, and wait for if any future complications of portal hypertension or EHPVO arise. But seeing the blood picture, early operation, early sound surgery may give relief to patient and address the concern of future if possible, if any hypersplenism, symptomatic hypersplenism syndrome.
So here you will consider surgery mainly for bleeding. That's the main indication here, isn't it?
Bleeding, I can manage sir endoscopy, sir. I can manage endoscopy.
Okay, but there is something else in addition to bleeding, which is making you consider
growth
surgery as an
retardation.
option, right?
Growth
Yes.
retardation is also there, sir.
Yes.
So
Though,
sound surgery. Yes. Sir.
yeah, I mean here, though in terms purely from a BMI point of view, she's not severely wasted,
Yes.
but there is a concern about height, isn't it?
Yes, sir.
Though in
Stunted.
the history, it is clearly mentioned that when it comes to academics, you know, she is not lagging behind, isn't it?
Yes.
Okay.
Why, can you tell us quickly why there is a issue of this growth retardation and all?
Ma'am, most likely due to deficiency of insulin-like growth factor, ma'am, IGF and IGF binding protein.
Do you think it is purely, you know, the primary disease process which is driving growth retardation here?
How many percentage of patients of EHPVO in children develop growth retardation?
Around, ma'am, 15 to 30%, ma'am, 15 to 30%.
In children, I say, in children. It is up to 40 to 50%.
Okay.
You asked for.
Okay, so with shunt, after shunt, the growth retardation will be reversed.
Ma'am, yes, in case of PSRS or in case of a major shunt, the growth can be reversed.
Yes, very good. So only shunt which is really going to reverse, really going to help for growth retardation is which shunt?
Major X, ma'am, major X.
Very good. So in this patient, we are not looking at major X shunt.
No.
So will this, in this patient, the growth retardation will be halted or reversed?
Even in case of PSRS, there is some incidents, some findings shows that growth spot can be observed after post-shunt surgery.
Okay. If the epiphyses are not yet fused.
Yes, epiphysis
Right?
not.
So that is the reason for doing an early surgery. That can be the reason, justifiable reason. In addition to failure of endoscopic treatment and these repeated episodes of bleeding and
Dr. Mahesh
Yeah,
wanted to get it.
sorry. Yeah, just are you happy with only the ultrasound and you asked for
Sir,
CT?
sir, I
What
can't
do
hear.
you prefer? You prefer
Sir, I
ultrasound,
can't hear.
CT, or MR with MR portovinogram?
Sorry, sir. Can you repeat, please, sir? Sir, I couldn't hear. There is loss of connection.
Okay. Are you happy with only ultrasound and CT, or you want a MRI with MR portovinogram reconstruction?
Sir,
Which one do you prefer and why?
Sir, ये LFT shows sir normal LFT shows there is no rise in alkaline phosphatase or GGT, sir.
Okay.
So I'm not expecting any sir portal biliopathy, sir. I'm not expecting.
Okay. No, I was asking regarding portovinogram.
Yes, sir. It will suffice, sir. It is, sir. It is equal as CT photogram, sir.
You are happy with CT?
And it will give also, sir. It will give better information towards the biliary tract. What is the status now? The biliary tract.
Okay. The ultrasound didn't show any site of bleed. Would you like to consider anything else other than the esophageal and gastric varices?
Sir, there was portal hypertensive gastropathy, but I want a colonoscopy could be done to rule out. But
there is blood in the stomach.
Yes, sir. Altered blood in stomach.
Hmm. Would you consider ectopic varices?
Yes, sir. Definitely. Yes, sir. Ectopic varices.
Long-standing disease.
Long-standing disease, sir. Multiple episodes of endoscopic treatment. Yes, sir.
Yeah. Okay.
So you are asking for a CT scan. So what information specifically you need in this case for an abdominal CT?
Sir, actually, I'm not unable to hear.
See, Ashirbad, you are asking for a CT, right? Can you hear me, Ashirbad?
It got disconnected.
Yeah, we'll have to log in again.
Sir, he just got disconnected, sir. He's reconnecting.
Okay.
Yes, sir. Yes, sir.
Yeah, Ashirbad, you are asked for an abdominal CT, isn't it?
Yes, sir.
You have an OGD, you have an ultrasound, you had clinical diagnosis, but what specifically are you looking for in abdominal CT?
Sir, in abdominal CT, I want to know the splenoportal, any extent of thrombosis of splenoportal, patent splenoportal axis, sir. Now,
okay, so what patency are you specifically looking for? Because you're planning treatment here, isn't it?
Yes, sir. Yes, sir. I'm looking for, sir, at least SMB and splenic vein confluence patency, sir.
Okay. Yes, that is an important information because if you have to plan surgery, then you need patency and healthy veins, right? Apart from that, on abdominal
apart
CT.
from that, yes, sir. If what are the shunts present, sir? If any splenorenal shunt, and what are the location of it? And in some cases, sir, left gastric, there are lesser shunts in the lesser curvature. I want to know them, sir. After that, sir, what are the status of renal vein, sir? If an anomaly is present there, if any branches of renal vein is present there, diameter, yes, sir, length of the renal vein, mostly, sir.
So I agreed with you regarding patency of veins, any anatomical, the details of the vessels which you are going to use for shunt surgery, right? And
Yes.
what is then why do you want to know the shunts?
Sir?
Why do you want to know the presence of shunt? Another thing which you mentioned was about shunts, right?
Yes, sir. Yes, sir. Sir, for better handling and most after ligation of such splenic artery, splenic vein difficult to find splenic vein. Of course, difficult. We find it difficult to identify the splenic vein. We have to relocate behind the pancreas till the SMB cell or portal vein. After that, sometimes we have to trace it from there, sir. So I want to ligate and safely move during surgery, sir. It will help me a lot during surgery.
So you want to know the shunts to identify, to get a better anatomical detail of splenic vein, or is there any other
Also
role?
that, yes, sir, if the spontaneous shunt has been already formed, sir, that means the splenic vein is already decompressed. So it will be not very dilated, and patient may not form a splenomegaly, or features of portal hypertension will be less, sir.
Can we get the CT report here? Or the images, sorry, not the report, the images.
You have control, Sashila.
Thank you. Plain CT shows, sir, there is no SIT, sir, and a huge splenomegaly, sir. Coming to, sir, portal phase. There are no ISBRD, sir. In liver margins looks normal. There is minimal coded lobe hypertrophy, sir, and multiple collaterals, periportal collaterals present, sir. Now tracing, sir, splenic vein and splenic vein and SMB confluence could be seen, sir. Patent, it is patent. And loss of in main portal vein trunk, sir. Loss of patency in most likely main portal vein trunk is affected.
Okay, so quickly tell us what are the CT findings and how it will help you to decide about the surgery.
Yes, ma'am. The splenoaxis, splenoportal axis shows, ma'am, there is splenic vein is intact and it is dilated.
Okay.
And now there is a most likely left renal vein is pre-aortic most likely in front of aorta.
what size of splenic vein you are looking at approximately? How much, what should
Yeah.
be the size you want or something like that?
It is now, I'm looking at minimum around 1 centimeter, ma'am. The present case shows at least around 1 centimeter.
1
More
centimeter.
than
If there is a patient who has splenic vein of 1.5 centimeter in diameter, you will be happy, or you are worried, or you are more than happy? I mean,
I'll be happy, ma'am. I'll be happy.
you will be happy with 1.5 centimeter.
Yes, ma'am.
Are there any concerns of a very big size of splenic vein?
Ma'am, very big size splenic vein may lead to, during procedure, ma'am. There may be due to thinning of portal vein, ma'am, splenic vein. There might be easy, very careful tissue handling may be needed.
Okay, it is very meticulous surgeon. You are very meticulous surgeon. There is no problem of tissue handling. But what is more concerned thing in if
If
the
more,
splenic
then I
vein
have
is
to.
a
Yes, ma'am. I have to do end-to-side anastomosis, and then more the aperture on the renal vein would be larger.
okay. And regarding hemodynamics,
Yes, ma'am, it will change because there already, if sound has been performed, already spontaneous sound is there, then the size would be less, and the change in physiology would be less. But here there will be more.
the thing is that if the splenic vein is really large in size, more than 1.5 centimeter or so, the shunt may not be very effective. There may not be a good pressure gradient. There has to be a pressure difference and a pressure gradient for the shunt to remain patent. So we neither want a very small diameter splenic vein, nor we want a very large splenic vein also.
Okay.
Right? In that case, you need to reduce the size of splenic vein a little bit so as to achieve good pressure gradient and good flow across the shunt.
Okay.
Okay. Okay, so now let us go ahead. You have decided that it is okay for you to go ahead with a shunt surgery. Which shunt?
Proximal splenorenal shunt, ma'am. I'll go for
Okay, end to
proximal
side
splenorenal.
proximal splenorenal shunt with splenectomy,
Yes,
right?
ma'am.
So what do you
Yes, ma'am.
any other things now you want to do before surgery, or you just want to ask your junior to keep the patient for the surgery, prepare him for
Ma'am,
the
I want to
surgery?
immunize the patient with pneumococcal, meningococcal, and hip vaccine 2 weeks prior to the surgery. At least 2 weeks prior to the surgery.
Okay. Ideally 2 weeks prior to surgery, you will immunize the patient. What else?
Yes.
Anything else?
Now, ma'am, platelets was 60,000, and I will arrange blood for that, ma'am. Hemoglobin
Okay,
was
platelets
10.
are 60,000 and your anesthetist says this is platelets are 60,000 and we are worried. What will you tell them? You will infuse platelets, or you will arrange platelets, or you will say no, go ahead? What thing you will advise?
Ma'am, I
Anesthetist,
will.
suppose anesthetist is a new person and she says that this much platelet, I won't induce the patient.
Yes, ma'am. I will talk with them. I will say that platelet cell function is maintained. It is only due to splenomegaly, portal
Yes.
hypertension. Platelets, there is thrombocytopenia. The count is decreased, but platelet cell function is normal. It is preserved.
Okay. So you will
What
ask
are the
her to go ahead.
guidelines?
Yes, sir.
Yes, sir.
What are the guidelines for platelet transfusion? You are aware of guidelines or no?
Yes, sir. Sir, institutional guidelines, sir, I may have adoption.
There are defined guidelines you can read up. Okay.
Okay, sir.
Sir, but before proceeding to surgery, are there any alternatives to surgery in this patient?
Sir, Sir, other than endoscopy, sir?
Yeah.
Sir, tips can be done, sir, but left portal vein, left intrahepatic portal vein is patent, sir. Tips can be done, sir.
But will it address the, the main portal
No,
vein?
sir, it won't address.
It won't, isn't
No,
it?
sir, it wouldn't. No, sir,
Because
it
the
won't.
entire main
Thrombosis.
portal vein is thrombosed, isn't
Yes.
it? So tips is not an option here.
Not an
Certainly
option.
not. Is there anything else?
No, sir, I don't know, sir.
Do a lot of shunt surgeries in your organization?
No, sir, not many, sir.
What is the
Few.
reason for that?
Sir, mostly, sir, patients are referred very rarely by the medical gastroenterologist.
Okay.
And
there should be a reason for that, right? I'm sure you'll
yes.
get cases. There should be some competing treatment options, right?
Yes.
You said in the history that I missed, I mean, we have skipped that, but you said the patient is on a tablet which is taken twice a day.
Yes, ma'am.
Have you given a thought over it? What it can be? Why it is twice a
it
day?
It is beta blocker, ma'am. Most likely it is a beta blocker drug, and it is given as a secondary. Now it is patient, in this case, it is given as a secondary prophylaxis. But in case of EHPVO, the role is minimal or controversial to say, but it seems it is being given, ma'am, in mostly.
It is given twice a day. You particularly mentioned, or the history, in the history it was particularly mentioned. Okay, so what should be the ideal dose of beta blocker? Not in EHP, as you rightly said, may not be in EHPVO, but for prophylaxis of radial bleed.
Yes, ma'am. Usually carvedilol given in 3.25 milligram, ma'am, BD, 1 tablet BD.
Okay, very good. And how much? What is the how you assess the response?
Ma'am, we assess by repeat endoscopy, mostly after the acute bleed by within 3 weekly. After that, yearly, ma'am, endoscopy.
Anyway, I was asking about response of beta blocker, but we have deviated from our topic of surgery. So let us proceed with the surgery.
So I mean, just to okay, we'll talk about surgery first. See, okay, what surgery will you do here?
Sir, I would like to do a proximal splenorenal shunt.
Okay.
Which splenectomy, which obviously includes splenectomy, sir, and devascularization of left side of the greater curvature of stomach to the fundus.
Do you have any other options?
So in this case, the liver is not so splenomegaly not so high, sir. That is 16 centimeter only. I can go for a central splenorenal shunt also, sir.
What are the indications of central splenorenal shunt? When you will do central splenorenal shunt?
Ma'am, when spleen is the splenomegaly is not very large. It is a mild to moderate splenomegaly, and we want to preserve spleen, ma'am. We can do a spleen.
We will always want to preserve the spleen unless there is hypersplenia, right? So what is the another indication, the situation where you would do a central splenorenal shunt? Or what are the prerequisites and what are the prerequisites, not all?
Prerequisites are, ma'am, patent spleen band with SMB confluence, and even IMB confluence is patent.
So when there is the splenic vein is little smaller in size, but the length is good enough so that in sideways it gets approximated,
To left now.
but the diameter is small, then to achieve a bigger anastomosis, you would consider this. But when what is the contraindication for this?
Ma'am, contraindication is splenomegaly, ma'am, because it doesn't address the features of large splenomegaly, severe splenomegaly.
The proponents of central splenorenal shunt don't consider splenomegaly as contraindication of that. Okay, because over a period of time, it is thought that it also takes care of the hypersplenism also. But the presence of ascites is contraindication for
Ascites
central
is a contraindication.
splenorenal shunt, absolute contraindication.
Yes.
Okay, so if the splenic vein is torn or if something happens and you lose the splenic vein intraoperatively, what you will do in this case?
In this case, I can go for a devascularization surgery. If splenic vein is thrombosed or during procedure is lost, tribal and lost, ma'am, I can go for a devascularization surgery.
Okay, but if it is okay, I mean, it is acceptable answer, but if all the expertise are available, is there any,
Major
higher?
excision, ma'am. Then expertise available, then we can go for a major exam.
Mesorex shunt is possible in this age and with the anatomy of the portal vein, given
Ma'am,
anatomy
left
of
portal vein was patent, ma'am. In city, left
okay.
portal vein was patent, ma'am.
Something more practical, something more usually done.
Portocaval shunt could be done.
Portocaval
SMB caval, SMB caval.
Okay, mesocaval shunt can be
Major caval shunt.
Considered. But yes, devascularization procedure, doing devascularization procedure is acceptable answer. Suppose if this patient has had eradication of the esophageal varices and presented to you only with this hypersplenism, so
Yes,
would you add a shunt procedure when there
no,
are
ma'am. I would
or
only
there is
go for
eradication of
splenectomy.
varices?
Then, ma'am, I would only go for a splenectomy. But, ma'am, I would still go for front surgery because patient is young, ma'am. Patient may develop bleeding in future, ma'am. So I would still go for surgery. And doing a splenectomy rules out the possibility of a splenic shunt, that is PSRS or any CSRS.
Yes, so you should still add a shunt surgery if a shuntable vein is available, right? Okay, so intraoperatively, what other things, special things you do? Do you give anticoagulation?
Yes, ma'am. Before clamping of the renal vein, we give at least 100 unit per kg given in IV, and after that, clamping of renal vein is done.
Sorry, what is the dose?
100 international unit per kg.
Okay,
Per kg
and then you continue it in the post-operative period. What are the post-operative anticoagulation protocol?
No, ma'am, we don't continue, ma'am. We don't continue, ma'am. But it can be continued for 7 days. After that, patient can be discharged with ecosprin for 6 months.
Okay, so as you said, various institutes have various protocols for the anticoagulation, and similarly for the Doppler. What do you do?
Yes,
Do you again see the patient, send the patient for Doppler?
no, post-operative we don't do, ma'am. It can be done post-operative day 7, ma'am. After that, but we don't do usually. We evaluate, follow up the patient with upper GI endoscopy. If you see there is a resolution or there is absence of an varices. After three months, ma'am. After 3 months, 3 to 6 months, we evaluate the patient with upper GI endoscopy. If there is resolution of varices, then we don't do any Doppler. But if there is still varices present or new high-risk varices present, then we go for a USG or CT direct, man, CCT.
Any
Uh,
specific reason why you don't want to do Doppler in the post-operative period?
No, sir, but it,
Say you pick up a early thrombosis. Is there anything you can do?
yes, sir, we can use interventional radiologist to make an pattern by passing doing thrombolysis.
Then why do you want to not do a color Doppler in the post-operative period?
So thrombosis rate in case of PSS, PSRS is around sir, around 10%, sir, in good institution. So we don't usually do.
Is it only 10 or is it higher than that?
So 10, but with due follow-up, the thrombosis rate increases to around 10 to 25%, sir.
Okay. There is no harm in doing
Yes, sir.
color Doppler in the
Yes.
post-operative period.
Post-operative, yes, sir, yes.
Akshaba, I had asked you a question about why the shunt surgeries, procedures are becoming less popular, right?
Yes, sir.
So, one, you mentioned about tips, right? Obviously, tips is not an
Yes.
option here,
Yes,
right?
sir.
Are there any other radiological interventions? If the patient here refuses, to undergo surgery, is there any radiological option here? See, patient is having multiple admissions and interventions here, right?
Yes, sir.
So yes, you have an option of continuing endoscopic treatment and then beta blockers. But then, the episodes are frequent. In fact, I think the last two episodes have been over a period of 6 months time, isn't
6
it?
months. Yes, sir.
So surgery is definitely a good option here. I agree with you that, a proximal sphenorenal shunt will not only take care of portal hypertension, but, here the hypersplenism as well. But is there any other option radiologically? I mean, you have seen the endoscopic results here. You know the
Yes, sir.
anatomy based on the CT. What is balloon occluded
Yes, sir.
transvenous
Barto can be
embolization?
done, sir, but portal hypertensive gastropathy, sir. Barto can be done, sir. The
Okay.
patient is having recurrent bleed. Barto can
So
be
do you
done, sir.
think this is a case where it can be considered?
Yes, sir. Yes, because patient there is bleed after 5 days after acute bleeding. There is still blood in stomach, though it is altered. There is still blood in stomach, sir. So and patient is endoscopy shows features of portal hypertensive gastropathy, sir. But will suffix, sir, for those kind of. And patient is having recurrent bleed. And the varices are grade 1 and 2, sir. Though there is 2 grade esophageal varices, but most likely bleeding is also from gastropathies.
Okay, so see, there was blood in the stomach, right? That is one. And
Yes.
then the varices in the esophagus they were small, isn't it?
Yes,
Most of them
small
are
and grade 1
obliterated.
and 2. Yes.
So how do you choose, case of BRTO?
Sir, only when there are no, the esophageal varices are well managed and
Yeah.
the bleeding complications are well managed by endoscopy, sir. And only the concern seems to be the portal hypertensive gastropathy. That is the other than the fundal varices and the bleeding from the gastropathy PHB, sir.
Yeah. Yes, and even if I think one of the endoscopy had shown a gastric varix, right? Without.
Yes, sir. Yes.
Yeah,
Yes.
yeah.
Yes.
So that's where, the initial thing about, CT, like, why do you do CT? Do you need a CT before BRTO?
Yes, sir. We need to see that we have to assess during BRTO, sir. We have to assess from femoral vein. If there is any shunt present to the retrograde maneuver, sir, so we have then shunt present which is connecting to the stomach, sir.
Yeah, so there should be a shunt which is present, isn't it?
Yes, sir.
So these are the things, like, of course, I mean, when we discuss about CT, Okay,
Yes.
so you should mention that, these are things I'm looking for. And there may be shunts. In this case, maybe a candidate for a BRTO, especially,
Yes.
in the setting of patient refusing for a surgical procedure.
Yes.
I think Dr. Sharvari, you are on mute, I think.
Okay, you've done surgery. So how would you follow up this patient now?
Sir, after surgery, patient is having uneventful recovery and goes out of hospital. Then I will follow up patient with investigation, that is with complete blood count. I'm expecting a rise of platelet count, sir, because splenectomy has been done. And I will send the patient on echosprin, sir, to rule out any early shunt thrombosis, sir, due to increased platelets, sir.
So when would you like, at what level of platelets would you like to start the patient on ecospirin?
Sir, we start usually when patient has more than 4,000 or 3,000, 4,000, more than 4,000. They achieve usually by POD day 3, sir, POD day 3, day 4, sir. So after that, we start.
4,000 what?
4 lakhs, sir, 4 lakhs, sir. Sorry, sir, 4 lakhs.
Are you sure about just at 4 lakhs you want to start ecospirin, or you would wait for a higher levels?
So usually when, sir, mostly, sir, 4 to 5 lakhs patient has continuous increase. We continuously do CBC, sir, there is always increase in platelet. So we discuss with ecosprin, sir. Sometimes we don't, when it is around 3 lakhs to 5 lakhs, we don't do usually, sir. But above of that, we do, sir. Most likely they stay around 7 lakhs, sir. And
Hello, can you hear me?
yes, ma'am.
Yes, I just wanted to clarify, or we wanted to ask you whether there is any difference between portal hypertensive gastropathy and fundal varices. What are the types of varices? What is the classification of varices? Gastroesophageal varices.
Yes, ma'am. Man, according to Sharin's classification, man, there is gastroesophageal varices and isolated gastric varices. In GOP1, man, both gastric esophageal varices type 1, there is both gastroesophageal varices along the end plus along the lesser curvature. But in type 2, there is gastroesophageal varices with fundus, man. But in case of isolated varices, there is isolated gastric fundus varices, and in type 2, there is gastric varices except in fundus of stomach.
So, and what is now portal hypertensive gastropathy? Is it same as this?
No, ma'am, it is not same.
Yes. So portal hypertensive gastropathy is a different entity. What is the difference?
Yes,
What is the meaning of portal hypertensive gastropathy?
ma'am, usually in case of portal hypertensive gastropathy, we cannot do a bending, ma'am. It is submucosal blood vessels are most likely engorged, ma'am. But
Okay,
in
so
case of
when
gastric
portal
varices,
hypertensive gastropathy develops?
and in case of log standing and which multiple treatment by endoscopy treatment has been done to the
Yes. So when the
gastroesophageal.
varices are eradicated in case of EHPVO and CPH, when the varices are eradicated and there is long-standing portal hypertension, then there is likelihood of development of portal hypertensive gastropathy. But in cirrhotics, it can develop on its own. So it is more related to cirrhotic patient, portal hypertensive gastropathy. So Borto can be a treatment for fundal varix. And what should be the treatment for portal hypertensive gastropathy? Borto will not treat portal hypertensive gastropathy. I wanted to tell you.
Glue is usually indicated for portal hypertensive gastropathy. Cyanoacrylate glue.
No.
Borto specifically, Borto, is a treatment for isolated gastric varix, right? Not portal hypertensive gastropathy. That's what, ma'am wants to tell you.
Yes. So portal hypertensive gastropathy is very difficult to treat.
Yes.
Okay. The bleeding from portal hypertensive gastropathy is very difficult to treat. You have to treat the root cause of portal hypertension. There can be things like APC or TIPS
Yes.
may help to treat, help to reduce the PHG, but it is definitely different from the fundal varices.
Okay.
Dr. Mahesh wants to. I think it's
Yeah,
9
I
o'clock
think
now.
it's time we can close.
Yeah.
Yes, if there are any questions from other seniors or Dr. Pradeep sir.
Yeah, I think Panda, you have done reasonably all right. Okay, this done well. But a couple of points. When the moderator asked you about an ultrasound in a portal hypertension, there are certain things in ultrasound you look for in portal hypertension. One is, of course, you will make it. You can diagnose a portal hypertension by looking at the varices. Second, you look at the cause for the varices. And third, you did not mention is about the planning of treatment. If the patient requires treatment, you should also look at the veins. Are there any shuntable veins available or not present? Or whether what is the diameter of it, what is the flow pattern of it by using a Doppler, and also about the renal veins, whether it is actually feasible for you. So all this information you can get in ultrasound. So there will be diagnosis, there will be etiology, and then planning of treatment also. You get an ultrasound and a Doppler. So you should be, and TIPS is not done for EHPVO. That we should be very clear. TIPS is basically for the, though some people have used it to negotiate it, but by and large, from exam perspective, I think TIPS is basically in case of a cirrhotic where you can get it. TIPS, EHPVO, we don't usually advocate. The other thing is indication for surgery. You should be very clear. This patient, why you want to operate. This patient can go on even for endotherapy. There should be some strong reasons for you to argue in favor of a surgery. One of the reason I feel is this patient lost to follow for 2 years, right? The patient was lost to follow for 2 years. So potentially this patient might not continue for the treatment. So that is one of the indication you should have argued that this patient is ideal for a shunt procedure. Because anyway, she might not be compliant with because it requires multiple sittings is one thing. And regarding portal hypertensive gastropathy, I think the sclerotherapy and EHPVO is not an answer to it. You should be able to reduce the pressure. To achieve portal hypertensive gastropathy bleeds, only shunt is the only answer where it brings down the pressure. So the treatment of a bleeding portal hypertensive gastropathy, if there are no shuntable veins, probably then you can have other measures which are not successful. The ideal treatment for portal hypertensive gastropathy is to reduce the portal pressure. That is possible only by a shunt. Otherwise, overall, you've done well. Now we have a Professor Shastri and Professor Jaswant here. Any comments from them? Then we can wind up after their comments. Sure.
Yeah, I think he's done fairly well. It's a fairly straightforward case. In a straightforward case, you should be very careful. Blunders like, offering tips and extrahepatic portal venous obstruction, I think should be avoided. Be careful of that kind of slips. They stand out in a straightforward case. Apart from that, well, it's a straightforward thing. You should do. There's no excuse not to do well in this kind of cases. That's what I like.
Jaswant, sir.
Yeah. Good morning, sir. Nothing much more to add, sir. Thank you.
Okay. If there are no more comments, can we wind up, Nagaraj, Sharvari, and Mahesh?
Yes, sir. We
Sure,
can.
sure.
Thank you, sir.
Thank you, Panda. Thank you, Mahesh, Nagaraj, and Sharvari. Thank you.
Thank you.